Okay, welcome everyone to PETOS. This is pediatric education that is brought to you in partnership through EMS for Children within the Bureau of EMS and Preparedness, Primary Children's Hospital, and the Utah Telehealth Network. We are excited that you guys have started to pick this up and use this for your CMEs because it's fantastic pediatric information, and that's what we're all about. We want to make taking care of kids easier for you. I will remind you that I will be asking for your email address sometime during this presentation in the chat. And that is how you will get your certificate. You will need to send me your email address. You don't do it now. Wait until I ask for it. That's how we verify, and that's how we were able to qualify for CME, is to verify your attendance in that way. So we will get started now. I'm pleased to introduce you to Dr. Joyce Soprano. She is an attending physician at Primary Children's, has been there as long as I have, which is a long time, and she was here before me. She is one of my mentors. I absolutely have learned so much from this incredible woman, and I am going to let her do any further introductions. And Joyce, go ahead and share your screen.
Great. Thank you, Tia. That was so nice. Yes, it's been 20 years, 20 and a half years since I started at Primary Children's, and it's been great. And Tia, how long have you been there?
Well, 23, but not in the ER, 12 in the ER.
Ah, well, it's a great place, and we certainly get our share of patients that you all bring in to us, and our fair share of abdominal pain. So hopefully you will find this interesting. If there's any audio or video issues, please someone speak up. Tia will be watching. And if anyone, I would like this to be interactive. I'll ask some questions, ask you guys, to answer some little quiz questions and scenarios. And so I'd really like people to be involved. And if you have questions, feel free to either put them in the chat and Tia will read them to me because I can't quite see the chat with all this going on. Or you can just unmute and ask me. I'm totally happy to have you do that. So let's go ahead and get started. I have, okay, already having a glitch. Can't get my, all right, hold on. There we go. I have no relevant financial relationships to disclose. So our learning objectives, okay, I have to already move you all here to the side. Learning objectives, I want to discuss the approach to assessing abdominal pain in children. So sort of the history and exam things that we think about in pediatric emergency medicine. We want to identify life-threatening causes of abdominal pain in children, and then also review some of the common causes of abdominal pain in children. And I'm really going to bring you all into our world because you may transport patients with abdominal pain, but you're probably not doing a ton of assessment of them unless they're like a fresh trauma patient. I correct me if I'm wrong, but I don't know how much you would be able to do before getting them to the hospital. And I quite honestly don't know how many calls you would get for abdominal pain. Someone may want to tell me that, if it's a common thing or not a common thing. So I'm going to bring you a little bit into our world and how we think about these patients and what we do in the emergency department. So in terms of overview, first thing to say is that abdominal pain is one of the most common complaints in children. I mean, it's like ranges in causes, and we'll go over a lot of them, but a very, very common complaint. Often prompts evaluation in the office or emergency setting. We get tons of patients in the emergency department with the complaint of abdominal pain. I think it ranks up there with fever as a chief complaint. And the differential is very broad, but most cases of abdominal pain are mild and or non-surgical. I think every parent thinks their child has appendicitis. And while appendicitis is common, and we're going to talk about it, most of the abdominal pain we see isn't secondary to appendicitis. We see lots of common causes like constipation, gastroenteritis, urinary tract infections, pharyngitis, viral syndromes. We'll go over these a little bit at the end. But then that all being said, there are several very severe and or life-threatening causes of abdominal pain that really must be identified. things like intussusception, appendicitis, volvulus, and trauma, and we will go over a lot of these as well. In terms of the history, the devil's in the details, and I think most of the diagnosis of abdominal pain can be made through the history and the physical exam, and you have to be careful and get a really good history. Age is important. If you have a teenager, you're not thinking intussusception. If you have a 1 month old, you're probably not thinking intussusception. So, the age will really help you a lot. Gender will help a lot. Many of these conditions are more common in males, some more common in females. We'll highlight a few of those. So that really helps you out as well. Whether they have prior surgery or congenital conditions can help. There's certain associations with congenital conditions such as congenital diaphragmatic hernia or trisomy 21 or various things that they may have had in the past, and surgeries of course always predisposes to bowel obstructions. Whether there's a history of trauma is important, and this is obviously your world. You're going to always be on the alert of trauma patients, and that can give you a clue as to the etiology of their pain. Whether they have associated symptoms such as fever, vomiting, diarrhea, cough, all the different review of systems things that we ask when we're evaluating patients really can help quite a bit. And then of course the characteristic of the pain. Where is it located? Is it generalized or focal? Is it we had a patient last night, left upper quadrant abdominal pain for a week and a half, just right in that spot. Turns out he had a regional colitis, probably infectious, but that was localized versus generalized. Is it all over? Would that indicate peritonitis or would it indicate constipation? Is it constant or is it intermittent? Something that comes and goes is less concerning than something that is constant and worsening over time. Is it worse when they move? Is it worse when they cough? Or the bumps, when they go over bumps in the road, in the car, does it make it worse? That might indicate that they have some peritoneal irritation or peritonitis. So you want to ask all those great review of systems questions. And then on your physical exam, the first things first, you got to look at the vital signs. Are there signs of shock to indicate that there is either blood loss, fluid loss, or tissue ischemia, and that we'll go over some scenarios where that may be the case. You want to look for the presence of fever. Of course, that's going to tip you off for something infectious. And look for tachypnea, which may indicate some subtle things like pneumonia or DKA. You want to look for bruising. If they give you a history of trauma, you want to see, are there any bruising patterns that tip you off to a higher likelihood of an intra-abdominal injury. If they don't give you a trauma history and you see bruising that doesn't fit, in a pattern that they can explain, are you worried about inflicted injury or child abuse? And then of course the abdominal exam, you want to look for distension of the abdomen that might indicate that they have a bowel obstruction or fluid in the abdomen, ascites or peritonitis. Where's their tenderness? Is it generalized? Is it focal? Are they guarding? Do they have peritoneal signs like pain when you shake their abdomen or when they jump up and down? Do they have a Robsing sign where you push on the left and they experience pain on the right? These would be some signs of peritonitis. And then do they have masses or organomegaly? Okay. So this is the first case. I have to move, you guys are half covering my slide here. Okay, so this is an 11-year-old girl who presents with diffuse abdominal pain after a motor vehicle accident. She was the lap belt restrained rear seat passenger in a car that was struck at a high speed. She has had non-bloody emesis twice. On exam, she is afebrile. Her heart rate is 130, respiratory rate 32, blood pressure 92/60. She has a capillary refill time of 4 seconds on her extremities, and her abdomen is diffusely tender with this bruise, which is a seatbelt sign. Okay, in terms of management, what would be the most appropriate next step in management? Now, obviously, this is sort of ER management. I know what you're going to do in the rig. You're going to do only one of these things, but that may be the same thing that we do. So what do people think? First person to yell it out gets the prize.
Just remember to unmute yourselves
Yes.
when you yell it out. In the chat, we have hold IV and B.
Yeah, I'm gonna
Bee,
do
lots
IV.
of bees, lots of bees. You guys are, I can't trick you. I'll trick you on the next one. So yeah, absolutely. So, you know, we have a patient who is exhibiting signs of shock. She's tachycardic. She has, you know, blood pressure that's in the normal range, but it's certainly, you know, right there on the edge, and she has delayed capillary refill. So she's showing signs of compensated shock, and she needs IV access, and she needs crystalloid. She may also need blood, but first things first, obviously we're going to treat her abnormal vital signs. So blunt abdominal trauma, something you all see often and are probably fairly comfortable with. So we see solid and hollow organ injuries that can occur from motor vehicle collisions, autopedestrian accidents, falls, sports injuries, and child abuse, and lots of other mechanisms, obviously, but these are some of the more common ones. In children 2 years and older with blunt torso trauma, any reported abdominal pain is associated with a 13% risk of intra-abdominal injury. In terms of solid organ injuries, isolated injury to the spleen is the most common that we see. In terms of hollow viscous injury, small bowel injury is the most common that we see. Clinical signs of intra-abdominal injury due to trauma, bruising, and we talked about the seatbelt sign, which is strongly associated with the presence of an intra-abdominal injury. Also distension, tenderness, and vital sign instability. And these are just some pictures of a few CT scans of different patients. So the top left is, you can see two different areas of liver laceration. Top right is a splenic laceration, pretty large there where the white arrow is, and on the bottom is a pancreatic injury. You can see that white arrow right there. You know, children have, relative to their size, they have pretty big solid organs, and their rib cages don't cover as much as adults, and their ribs are softer, and so children have a high risk of having solid organ injury from blunt abdominal trauma. Now, how about this little one? This is a 16-month-old boy. He presents with abdominal pain and vomiting after a fall at home. He reportedly fell off the couch earlier in the day and has been complaining of abdominal pain and has had 4 episodes of non-bloody, non-bilious emesis. He's afebrile. He's tachycardic, a heart rate of 150. It's a little high for a 16-month-old. Respiratory rate at 34, blood pressure is okay, 80/50. He has a distended abdomen that's diffusely tender, and he has the following that you are doing a very careful exam because your worry meter is high, and you see this on exam. So what does it make you think? I can only see Jimmy Lampy. You're like the only person on my screen, so I'm going to pick on you if no one else talks. What do you think?
It does look like child abuse to me.
Yeah.
I mean, based on the picture.
Yeah. Yeah. And this one, you know, if they were all this easy, we would be not missing any child abuse, right? So here you have it's a slap bruise. It looks like fingers there on the side of the face. And, you know, you have to really check the head, the ears, the angle of the jaw, the neck. You know, you have to, when you get these patients and the history is kind of sketchy, you got to look for this just to tip you off. Could there have been abuse? Because, you know, fall off a couch, as one of our radiologists said, there's a lot of mean couches out there. A lot of kids falling off couches, getting bad injuries that you shouldn't normally get from a 1.5 foot fall. So we're super worried about this kid. Non-accidental trauma is a common cause of intra-abdominal trauma in children. Liver injuries, especially the left lobe of the liver, because that is where they would typically take the blow to the epigastric area, accounts for 2/3 of all hospitalizations for visceral injury due to non-accidental trauma. But pancreatic injuries and duodenal hematomas have an increased occurrence in abused children compared to, say, children who've been in a motor vehicle collision. So when we see pancreatic injuries and duodenal hematomas in a young child, and the history is, you know, kind of sketchy, and they haven't been in a big motor vehicle collision, we're really worried about child abuse. And it's because the concentration of force usually it's a blow, a punch, or a kick right to the epigastrium. The pancreas and duodenum are sort of fixated by the ligament of Treitz, and they will, especially the pancreas will get, that blow to it, and then it will compress against the spine. And so they have a really high risk of injury. Making the diagnosis in absence of a history of trauma can be very difficult, especially if the evaluation is delayed, which happens a lot in the child abuse patients. So, they may come into the ER and the parent says, oh, they're, vomiting and they have abdominal pain. They're not coming in saying, and we punched them 2 days ago, so you have to, be a little, have your suspicion up if you don't have an explanation. And you always look for those minor injuries or bruises elsewhere that can be a clue to the presence of intra-abdominal injury due to abuse. We have a heightened suspicion if the history is inconsistent with the injuries, if the history is vague or absent, if the history changes on repeated versions given by the same caretaker, or there's conflicting histories given by different caretakers. That always worries us. If injury is attributed to young siblings, like his 2-year-old brother hit him in the stomach, that's kind of a suspicious story. Or if the history is inconsistent with the developmental stage of the child. And remember, those who don't cruise don't bruise. If you see bruising on a child who's not yet cruising, you really have to be worried about that. Okay. So here's another case. A 7-year-old boy presents to the emergency department with right lower quadrant abdominal pain for 1 day. He has nausea and vomiting for the past 2 days with occasional diarrhea. His pain originated in the periumbilical area and then migrated to the right lower quadrant. On exam, he has a fever. His heart rate is 105, respiratory rate 16, blood pressure 110/80. He's diffusely tender, but especially in the right lower quadrant, and his white blood cell count is 21,000. So what would we do next in the emergency department? Have a lot of options. We can get x-rays, we can call our surgeons, we can just do serial abdominal exams, CT scan, ultrasound. What do people think? Any ideas?
Some in the chat are saying B.
Yeah.
And then another says ultrasound.
Okay. Anyone who said B, want to tell me why? You can unmute and tell me.
Because it's quite dangerous.
Yeah. So B is correct in this scenario. Hold on, I gotta find my arrow. B is correct. And the reason is this sounds like a slam dunk appendicitis. We're going to talk about how we kind of get to that. But if we have a slam dunk appendicitis patient, we can usually just call the surgeons. We don't have to prove it by imaging. The problem is that the slam dunk appendicitis isn't the common, they're kind of rare. So we wind up doing these other things, but in this case, this sounds pretty slam dunk, and we'll talk about why that is. So acute appendicitis is the most common indication for emergent abdominal surgery in childhood. Like I said, every parent whose child has abdominal pain thinks they have appendicitis. That's not true, but we do get a lot of appendicitis because we're a referral center, and it's a common thing in children. It presents most frequently in the second decade of life. Fewer than 5% of patients with appendicitis are less than 5 years of age, and it is very difficult to diagnose in especially the first 3 years of life. Boys are more commonly affected than girls. So if you have like an 11-year-old boy with the history like that I gave you, you're pretty sure that that's appendicitis because they're right there in that sweet spot of age and gender, and it makes it a little bit easier. Why do we want to make the diagnosis of appendicitis? Well, the risk of missing it or having a delayed diagnosis is we worry that there's going to be a perforation, and that can cause complications down the line. It can cause a prolonged hospital stay, lots of antibiotics. They can get sepsis from it. So we really would rather them not perforate. The risk of perforation, it depends on the age. So in neonates, it's almost 100%. In young children under 5, it's anywhere from 50 to 100% are perforated by the time we make the diagnosis of appendicitis. Once you get over 5, it's less common because the kids can give you a better history, but even in adolescents, 10 to 20% are perforated by the time we make the diagnosis. Classic features are the ones that I presented in the case. So you have a kid who loses their appetite. They have periumbilical abdominal pain that migrates to the right lower quadrant within 24 hours. It hurts more when they move. They have vomiting. They develop fever after about 24 hours or so. On exam, they have right lower quadrant tenderness, and they have localized peritoneal irritation, guarding, rebound tenderness, maybe a positive Rovsting sign. That is classic appendicitis. When you look it up in the textbook, that's what you see. The younger children, and children in general compared to adults, and the younger they are, the less classic the presentation is. So it makes it really hard to, can make it really hard to make the diagnosis. There's lack of migration of pain in half the kids. So when we say it usually starts periumbilical and then moves to the right lower quadrant, that's only half the patients. Some kids still have an appetite. There's only, 60% of kids who have anorexia when they present. So that's not something you can always hang your hat on. There's no rebound tenderness in 52% of patients. I personally don't even test for rebound tenderness. I think it's one of the least sensitive ways. I go with just if they have focal tenderness in that right lower quadrant. That's really been shown to be the best indicator of the presence of acute appendicitis. So we have a algorithm that we follow in the emergency department. We score patients. We give them what's called a pediatric appendicitis score, which you can see in the box on the right side. They get points for different symptoms. So if they have the right lower quadrant tenderness on light palpation, that's 2 points. If it hurts when they cough or jump, that's 2 points. Anorexia, 1, fever, you can read the list there. So you add up all the points, and then on the algorithm, you can see if they have a pediatric appendicitis score of 1 to 3, that's pretty low. We have them follow up with their pediatrician or come back to the emergency department or sometimes even the surgery clinic in 24 hours if they're not improved. If they have a really high pediatric appendicitis score of 8 to 10, that was the case that I presented to you guys, then pretty much we can call surgery and have them evaluate them. If they're in the middle, they're 4 to 7, we will often get an ultrasound. So that's so there was someone who answered get an ultrasound. That would be our management if the patient was in that sort of middle score, and then take it from there. So appendicitis, very common. We don't want to miss it. Parents think their kids have it, but overall it is the most common cause of emergent surgery and abdominal surgery in kids. Okay. 15-month-old girl is brought to the emergency department with vomiting and abdominal pain for 1 day without fever. She's alert. She's non-toxic appearing. She has normal vital signs. Her abdomen is soft, but she's got tenderness sort of in the mid-right abdomen. She guards there. She doesn't like if you push right there in the mid-abdomen. And while you're caring for her, she has an episode where she starts crying and she draws her legs up to her abdomen. It's really, really fussy. It lasts for 10 minutes or so and then seems to subside. So with that history and what you're observing when you're taking care of her, which of the following would be appropriate to evaluate this patient? We have a contrast enema, abdominal CT scan. We could do a bowel clean out. We can do stool cultures, and we can do an abdominal ultrasound. Any thoughts?
In the chat, we have a couple of answers for E.
Okay. And what are people thinking? What condition are you thinking about?
There's a C and now a BD.
Okay. Anyone have any diagnoses ideas?
Maybe some intussusception with its when it coming and going like that.
Yeah, excellent. Sorry, I keep losing my arrow there. Yeah, so this to me would make me very worried about intussusception. Now you could, a constipated kid could present this way, but the episodes of the crying out and the drawing up of the legs really, and the age really worry you about intussusception. So let's go through that diagnosis in some detail. So intussusception is the most common cause of acute intestinal obstruction in infants. It occurs most commonly in children less than 2 years of age. 6 months to 2 years, up to 36 months is sort of the sweet spot, but 10% occur in children older than 5 years of age. Those children usually have what's called a lead point, a reason for the bowel getting into the intussusception occurring. And so what happens, you get an invagination of a part of the intestine into itself. So you can see in the diagram, the small intestine, it has like pouched into the colon. And that location, ileocolic, is the most common location for intussusception. So 90% of them occur in that location. The rest occur in the small bowel. So there'll be like a small bowel to small bowel intussusception. They can propagate all the way through the colon as far as the rectum. And I had an infant, a 1-month-old once, where the intussusceptum was coming out of the rectum, actually was protruding from the rectum. And that is a pretty dramatic finding. Most cases are idiopathic. They just occur. They can be preceded by a viral gastroenteritis or a cold in like 30% of cases. But some kids will have what's called a lead point, and that will be the reason for this occurring. So lead points are things like inflamed lymphoid tissue or Peyer's patches, tumors, lymphoma can do it. And then I had a baby just the other night, who had a small bowel intussusception, a little baby with trisomy 21, who had a Meckel's diverticulum. And that was the lead point. That baby went to the operating room and got a resection of the Meckel's. And then in taking the history from the parents, that baby had bloody stool in the past that they attributed to constipation, where now we know that bloody stool was from the Meckel's diverticulum, which then became the lead point for the intussusception.
Joyce, there's a question. Is the recurring pain due to peristalsis? What's causing them to hurt?
Yeah, so they get peristalsis, causes this crampy, colicky abdominal pain. You have irritated mucosa. You have bleeding into the bowel. And so in general, it's painful, but then when they get this peristalsis, they get more of that colicky. And I think that's why they tend to writhe and drop the legs. That's a great question. The classic presentation is the sudden onset of intermittent severe colicky abdominal pain with inconsolable crying and drawing up of the legs occurring every 15 to 20 minutes. Often it's followed by vomiting. It can be bilious. Actually, this baby that I had the other night was bilious, did have bilious emesis. They have these alternating episodes of irritability and lethargy. And it's really interesting, especially in the youngest kids. They can just come in with lethargy. I mean, they can look like a toxic ingestion. They could look like a child abuse. They just come in like pale and lethargic looking. And it can be hard to sort out that it's an intussusception, but we're kind of alert to that when we see a young baby with that type of mental status, that it could be an intussusception. Classically, you would feel a sausage-shaped mass palpable in the right abdomen, and they can have either gross or occult blood in their stool. And classically, they have what we call currant jelly stool. And that's usually a late finding. I'd say most of the kids with intussusception that I see don't have visible blood in their stool at the time that we make the diagnosis. Maybe that's because we're, pretty good at making this diagnosis early in our ER. And so it hopefully hasn't progressed along too much. Now, the baby I had the other night did have grossly bloody stool and bilious emesis. This classic triad of abdominal pain, sausage-shaped mass, and currant jelly stools is only seen in about 15% of patients at the time of diagnosis. So, again, the textbook description isn't, we don't always see that. And so we have to just be suspicious of this diagnosis. Up to 20% of the very young infants don't have obvious abdominal pain. About a third of patients don't pass blood or mucus, and a third do not develop the abdominal mass. So we do a lot of ultrasounds for intussusception to rule it out. which is an easy study to do. It has, it's really our diagnostic imaging modality of choice. It has great sensitivity and specificity for our ultrasonographers who are very experienced in doing it. The negative predictive value is high. So if they do it and they don't see the intussusception, we're pretty confident that it's not there. What you see is this target or bullseye sign. You see layers of the intestine within the intestine in the right lower quadrant. It's pretty a pretty impressive view there. We used to use a lot of x-rays in these patients. We don't so much anymore, but if you did get an x-ray because you weren't sure what was going on initially and you got an abdominal film, you might see signs of obstruction. The top at left x-ray is a small bowel obstruction. You can see those dilated loops with this very smooth edges. That's small bowel. And there's a lack of colonic gas. You don't see much gas there in that distal colon. You might see a target sign, 2 concentric radiolucent circles imposed by the right kidney, which is where the intussusception usually occurs. You can see a crescent sign, which is this other x-ray. You see that white arrow. This is the soft tissue density that's projecting into the gas of the large bowel. That is the intussusceptum. You can see an intracolonic mass, lack of air in the cecum. You can even see free air if they have perforated. So lots of sort of subtle signs, but still the ultrasound is really our gold standard now. So what's the treatment? Air contrast enema usually will do the trick. It can be both diagnostic and therapeutic. So if we don't see the intussusception on an ultrasound, or we go straight to air contrast enema, you can diagnose it as well as treat it, because the air will reduce the intussusception about 70 to 85% of the time. It's less likely to be successful if the child is very young or very old being over 5 years, or if they have had the intussusception for a long time, or if they look like they have a bowel obstruction on x-ray. It's a little less likely that they're going to get it reduced. There's a very small risk of perforation with an air contrast enema. Something to keep in mind is that the recurrence rate is about 10% for intussusception. And 50% of those would be in the first 72 hours, but not necessarily the first 24 hours. The recurrence of intussusception is more common in the older kids. And if they have multiple, yeah.
Sorry, can you describe what an air contrast enema is?
Yes. So it's essentially a double contrast. So in the old days, they just did barium enemas. So they just filled the bowel with barium and watched the barium go from the rectum all the way up the descending colon, transverse, and ascending colon until it reached the intussusception, and that pressure would reduce it. Now they do it they use just a little bit of contrast, barium or gastrographin, I'm not sure which they use, but they use mostly air, and they pump air in through the rectum. It fills the colon and then comes around and reaches the intussusception, and then the air pressure will reduce the intussusception. In patients who have multiple recurrences of intussusception, that's when we're starting to think, is there something underlying this? Is there a lead point? You know, do they have a polyp? Do they have a tumor? Do they have a Meckel's? And often those kids will go to the operating room to look for that lead point. Okay, here's another case, a 3-week-old baby boy who is brought to the emergency department who has bilious emesis and intermittent crying episodes for the last 2 days. He has had a difficulty feeding since birth. He's had multiple formula changes. Vital signs are temperature of 37.8, a heart rate of 200, respiratory rate of 60, blood pressure of 70/30. He appears ill and mottled. His abdomen is distended with generalized tenderness. You obtain this x-ray. Okay, after appropriate fluid resuscitation, which of the following should be done next? Any thoughts? Tia's gonna tell me what people are throwing out there. Any ideas? This one's a little tricky.
Got a couple of D's.
Couple of D's, okay. D people, what are you thinking? No one's saying.
Patrick, what are you thinking?
Okay, I'll let you guys slide. Okay, so this kid is in deep doo-doo. This kid needs an exploratory laparotomy pronto. So we wouldn't stop for any imaging on this child. We would just call our surgical consultants. So this patient has a malrotation with a midgut volvulus. So this is a condition where there's a malrotation of the bowel as a congenital anomaly. So the way the bowel is positioned in the abdomen, it's associated with an abnormal fixation of the mesentery. And this results in a tendency for the bowel to twist and obstruct at points of the abnormal fixation. So normally, if you look at this picture here, normally the duodenum comes around and then it makes like a C and comes across the midline. This one is just coming down straight. And so what happens is it can twist around here and cut off the blood supply. Complete volvulus of the bowel for more than an hour or two can totally obstruct blood supply to the bowel, leading to complete necrosis of the involved segment. And this is devastating. I mean, we have seen children come in and, within hours, they've lost, half their small bowel. It's really awful. And children who've died from this because they've necrosed so much of their bowel that it's incompatible with survival. When it involves the midgut, the entire small bowel and ascending colon can be lost. It also causes awful, sepsis and metabolic acidosis, and it can be really horrendous. The diagnosis should be considered in any infant who presents with bilious emesis and abdominal pain. About 30% of children with intestinal malrotation present with midgut volvulus before 1 month of age. So 1/3 present in the first month of life. A little over half present before the first year of life, and 3/4 present before 5 years of age. But we can see intestinal malrotation with midgut volvulus in older kids. 60% of children have an associated anomaly. So this is where that history of congenital anomalies and past surgeries helps you out. So congenital diaphragmatic hernias would be the most common associated anomaly. Cardiac anomalies, especially when they have like situs inversus or heterotaxia syndromes, omphalocele, gastroschisis, intestinal or esophageal atresia. So many different things that can predispose to malrotation with the midgut volvulus. Common symptoms in infants: vomiting, and typically it is bilious, as 90% of children will have vomiting. Many of them are hemodynamically unstable when they present with shock, signs of shock. There's abdominal distension, though that's not always present in young infants. You can't hang your hat on it. They have abdominal tenderness. They can have peritonitis once they're perforated. Pain is usually constant and not like colicky in nature. It's usually a pretty constant symptom. And then they can have hematochezia once they have a lot of bowel ischemia and bowel necrosis. And in older kids, the older kids who come in with this, the 5, 6, 7-year-olds, they present with chronic episodic abdominal pain and vomiting over weeks to months to years. I mean, some of these kids will have, like, parents will be like, every so often they just get this horrible abdominal pain, and it lasts for, I don't know, hours, or, usually it's pretty short-lived. And it's probably intermittent volvulus that goes away. And so it's not until they're older that they get diagnosed. That's a pretty interesting presentation. So on abdominal x-ray, it can be normal, can be gasless. It can show mild intestinal dilation. You can see here that the child has what we call a double bubble sign. So there's partial obstruction of the duodenum that causes distension of the stomach and the first part of the duodenum. So they get these kind of two areas of distension. And then if they're perforated, you can see free air. If you put an NG tube down and you can get it into the first part of the duodenum, it may be positioned abnormally. And then if you have time to get an upper GI, if the child is stable, it is the study of choice. It has 96% sensitivity to diagnose this disorder. You will see a misplaced duodenum with the ligament of Treitz on the right side of the abdomen, which is the wrong side of the abdomen. You don't see the C loop, and you can see this corkscrew appearance of the duodenum in the right upper quadrant. Sometimes they have complete obstruction of the duodenum. You don't want to see this. You get very nervous when you see this. Call your surgeons quickly. Okay, here's another 3-week-old who's brought in with bilious emesis and poor feeding for 2 days. This child has a history of vomiting and constipation since birth. There have been multiple formula changes as well. Now, this child has a markedly distended, tender abdomen, no stool on rectal exam. And when you do the rectal exam, you get a big shootout of liquidy stool comes out. What do you think about this? Does this make you think of anything? Constipation since birth. Any takers, Tia?
I have a D.
Okay.
And a C.
Okay.
Allergic to formula.
Yeah. Now, if it wasn't for the constipation since birth, I would maybe go with that. And those formula babies usually aren't too distended and tender, but it's a good thought. This kid needs a contrast enema because this child has Hirschsprung disease. So Hirschsprung disease is another congenital anomaly where there's absence of the parasympathetic ganglion cells of Auerbach's plexus. They're supposed to be between the circular and longitudinal muscle layers of the colon, but they're absent. And so what happens is they get spasm and abnormal motility for that segment where those parasympathetic ganglion cells are missing. So it can cause complete obstruction or chronic constipation. The length varies. It can be short segment or very long segment. You can see here in the picture, normal, you see these little yellow dots are the ganglion cells on the left side. On the right side, it's missing those ganglion cells in the distal part. That's the little skinny part. And so the proximal part gets all distended because it's trying to push against this part of the colon that doesn't have the normal ganglion cells, so it won't relax. So they get this big distended proximal colon and they get this tight distal colon. And so the kids get chronic constipation and obstruction. This is much more common in males, a 3-to-4-to-1 ratio. It's also associated with several chromosomal abnormalities, especially Down syndrome, as well as all sorts of different congenital anomalies in about a quarter of patients. Most patients are diagnosed in the neonatal period because they have delayed passage of meconium. So babies should pass meconium in the first 2 days of life. And if they don't, we in the nursery start worrying that they could have Hirschsprungs. In fact, I don't think you can get out of the nursery without passing stool. I don't know if anyone on this call has had a baby recently, but I'm not sure you get out of there until you have poo come out of your body. The neonates who are diagnosed usually have abdominal distension. They can have bilious emesis in the first couple of days of life, and they have this what's called the squirt sign. So if you do a rectal exam or any rectal stimulation, it kind of releases this aganglionic segment, and all the poop just comes squirting out. So again, most patients diagnosed young, though we have 10% of patients who are diagnosed after 3 years of age. Or lots of, toddlers. I've diagnosed 2-year-olds, 18-month-olds with Hirschsprungs. And what they present with is chronic constipation. They tend to have these very distended abdomens, and they tend to have failure to thrive. So they're little skinny kids with these big distended abdomens and chronic constipation. Parents will say, well, they don't stool very often. And when they do, it's like this big massive stool because they have this spasmed section of colon. Rectal exam usually reveals no stool in the vault. Abdominal X-ray usually shows signs of distal intestinal obstruction with decreased or absent air in the rectum and dilated proximal bowel loops. And you can see this is a contrast enema, which is the study of choice. This is the part of the colon here that's very skinny. This is the abnormal part. And then the big distended colon proximal to it is normal in terms of its innervation, but abnormal in terms of its distension because of all this sort of, buildup of contents and trying to constantly push against this abnormal section. The transition zone between the contracted aganglionic bowel and the proximal dilated ganglionic bowel is diagnostic, seeing that transition zone. And this is a surgical condition. Okay. 6-month-old girl presents with irritability and vomiting for the past 3 hours. On exam, she's afebrile. Her vital signs look pretty reasonable for a 6-month-old. And she has this firm, discrete mass palpated at the inguinal ring. What's the most appropriate next step in management? Any ideas? Send her right to the OR, try to reduce something, order an ultrasound, order a CT scan. Anything?
Got a D.
Okay. Okay, so we would get an ultrasound on this child. This is a girl, and bulges in groins in girls make us nervous because they are often ovaries, and they can be ovaries that are torsed. So it's hard to differentiate that from an inguinal hernia that may or may not be incarcerated. So let's talk quickly about inguinal hernias. They're fairly common. We see them in 1 to 5% of all newborns, about double that rate in premature infants. Much more common in males than females in terms of the presence of an inguinal hernia. They're more common on the right side than the left, which is a fun fact. And most of them occur in the first year of life. You can see here in the diagram you have on the left a normal scrotum. In the middle, you have bowel herniating down all the way in to the scrotum next to the testicle. And then you have in the one on the right, the inguinal hernia just up into the canal. Now, while inguinal hernias are more common in males, incarcerated inguinal hernias are more common in girls than in boys. But in girls, it usually involves the ovary rather than the intestine. The ovary actually herniates down into the inguinal canal in girls and can torse. And that's why in the scenario, we would get an ultrasound on the girl because I don't want to be pushing, trying to reduce an ovary. I'm not jamming on an ovary, trying to push that thing back out. So we always want to make sure we know what we're pushing on when it comes to a little girl. Symptoms are irritability, crying because of the pain. Occasionally they vomit if they're obstructed. They have this firm, discrete mass that you can palpate at the internal ring that may or may not extend into the scrotum in boys and into the labia majora in girls. And in boys, it can be really hard to differentiate an acute hydrocele from an incarcerated hernia. I have been tricked, more times than I haven't been. So I usually err on the side of getting an ultrasound, even in the boys, because quite honestly, I don't want to sedate a baby and try to reduce a hydrocele. And then I'm not getting it. I can't reduce it. And then I got to wake the kid up. Then I have to call the surgeon. Then they're coming down. Then we're sedating them again. I'd rather know what it is the patient has than guess. So I get a lot of ultrasounds on these kids. Incarcerated inguinal hernias are, I'd say they're fairly uncommon. Usually the scenario is there's a bulge, especially in the boys, a bulge. By the time they get to the ER, it's like gone already. The kid's been asleep in the car and geez, we open up the diaper and the hernia is gone. But again, ultrasound is diagnostic for all girls with inguinal mass and many of the boys if you aren't sure. We can reduce these in the emergency department. We're successful most of the time and less likely to be successful in the younger patients or ones where the hernia has been out for longer. And this is just a diagram of how we do it. You have to kind of extend the hernia down towards the scrotum and then kind of squish the fluid out up through the inguinal ring, rather than just pushing on the inguinal ring. That won't work. You kind of have to elongate it, milk that fluid through, and then you can often push it up. Okay, so a summary of serious and or life-threatening causes of abdominal pain that we have talked about. There are others, but these are the ones we've talked about. We've talked about trauma, we've talked about acute appendicitis, intussusception, malrotation with midgut volvulus, Hirschsprung disease, and incarcerated inguinal hernia. The one that frightens us the most is malrotation with midgut volvulus. This is the one where kids can die, babies, infants can die fast. Or lose major parts of their bowel. And this is the one that strikes the fear in us as a pediatric emergency medicine physicians that we're going to miss this and send a kid home, and they're going to come back with a devastating condition. So we are always on the alert for this condition. Okay. We have about 10 more minutes. Let's talk about the common causes of abdominal pain in children that are the one, not in addition to what we've already talked about, but these are the things we see all the time. I mean, like I worked the overnight last night. I saw a child with a urinary tract infection. I saw a child with gastroenteritis. So, you know, these are common things. So viral gastroenteritis, whether it's viral or bacterial. Oh, I saw a kid with colitis too. Did I say that? These are the common causes of abdominal pain. They're crampy, they're vomiting, they've got diarrhea, they have a colon distended with fluid, that hurts. So we see lots of abdominal pain from gastro. Urinary tract infections, especially in girls under 5, often present with pain. The girl I had last night had fever and shaking chills, and she was little, she was a toddler, so she didn't talk super well, but she'd say, telling her mom she had to poop. And it was that she must have been feeling pelvic pain from the urinary tract infection. And we got a urine on her and it was positive. Pneumonia with or without cough or abnormal lung exam. This always trips up residents because I'll say, look, could they have pneumonia? And they say, well, they're not coughing. Well, that doesn't help you in kids. Kids can have pneumonia without a cough, and kids can have pneumonia without an abnormal lung exam. Usually if they're presenting with abdominal pain because of pneumonia, it's a lower lobe pneumonia, like this one here. You see it's a left lower lobe. It's kind of sitting close to the diaphragm and irritating the diaphragm, and they have referred pain. And then pharyngitis with or without a sore throat. Again, I'll say to the residents, how'd their throat look? And they're like, well, they don't have sore throat. I said, you need to look at the throat because they can have pharyngitis. They may not be saying their throat hurts, but they have abdominal pain. They can have vomiting. They can have headache. And those are sort of classic symptoms of strep. So, we're always looking for these. And then we have common causes of abdominal pain in children without fever. Constipation is, there's 2 pandemics. One is COVID. The other is constipation in children. Lots of constipated kids out there. They present with colicky pain, history of infrequent stooling, retention behaviors like the crouching or they often will hold in their poop, fecal incontinence because they have liquid stool that leaks around. They can have mass palpated on exam, either suprapubic or left lower quadrant. And you can see this x-ray. I hope you guys can see my arrow. This is just a rectum filled and distended with stool, and there is stool all the way around here, ascending colon transverse. Tons and tons of stool there. Ovarian torsion is difficult to diagnose, easy to miss. These girls usually present with severe colicky adnexal pain and vomiting. It can be intermittent and make it tricky to diagnose. Usually there's a cyst that is causing the ovary or the fallopian tube to twist. And you just have to have a high index of suspicion and get an ultrasound, a pelvic ultrasound on these girls. Testicular torsion can present with abdominal pain without testicular pain, or it could be an adolescent boy who doesn't really want to tell you his testicles hurt. So he says his abdomen hurts, which is why we always have to do testicular exams when males complain of abdominal pain. It has to always be done. We've missed testicular torsions because we haven't done the testicle exam. Usually the testicle is elevated, it's twisted, it has a horizontal position, which in the sketch you can see the testicle on the diagram on the right is lying horizontally rather than vertically, and they will usually have an absent cremasteric reflex. That's when you scratch the inside of the upper thigh and the testicle moves up and down. When it's twisted and torsed, it won't have that up and down movement. And then two more conditions, Henoch-Schönlein purpura. Once you see this once, you never forget it. This is a systemic vasculitis. The kids classically have this purpuric rash on the lower extremities from the buttocks down. They can have some scattered lesions on the upper part of the body. And it's the vasculitis that involves the whole body, including the GI tract, and they can get abdominal pain. They will often have ileal intussusceptions that come and go and don't require surgery, but sometimes the abdominal pain will precede this rash and can be difficult to make the connection at first. And then diabetic ketoacidosis, lots of our DKA patients present with abdominal pain along with the other symptoms. So you know, as long as you're taking a careful history, you'll get a history of polyuria, polydipsia, vomiting. They may have small breathing. They can often be confused as having a primary respiratory condition, but you just have to get a good history. The abdominal pain with DKA typically is, I think it's part of the acidosis and the dehydration. It's pretty rare. You always have to be thinking, could they have appendicitis? But quite honestly, usually they don't, and it goes away when you treat the DKA. Okay, so in summary, abdominal pain is a common complaint in children. Most causes are mild and or non-surgical. Serious and life-threatening causes of abdominal pain must be recognized and managed quickly. And then the devil's in the details of the history and the physical exam, which are essential for making the correct diagnosis. Any questions?
This would be a good time to unmute, but I do have a question. So Joyce, obviously they're in an ambulance, they are going to get a call for abdominal pain. How do they know which one's lights and sirens and which one's not? And I know the answer is probably they won't know, but what tips can you give them?
No, I think it's a great question. I mean, your lights and sirens if they have signs of shock, I think, because then you're worried that it's trauma that you either knew about or you didn't know about, you know, abuse. So that always worries me. Or they have, the thing that would worry me the most is the malrotation with volvulus. And those kids have got to get to us fast because literally it's like hours. Torsions are, you know, you really have to be high on the priority list as well, but not, I think traumas and volvulus are the two that are the most time sensitive. I would say that some of the worst abdominal pain I've ever seen is constipation. I mean, these kids they can be in so much pain. I remember seeing a child once who came in, he was in so much pain. He looked so bad and he delivered like a 10-pound stool in the emergency department. This thing was massive. And the change in him after this stool came out, I mean, he was like, looked so much better, but it was impressive how bad he looked when he came in. And so, you know, the degree of pain isn't always, it doesn't always correlate with the likelihood that they're going to need surgery. Constipated kids have a lot more pain than appendicitis kids, if you ask me. So it's a tricky thing. Abdominal pain is definitely a tricky thing.
Is there a drug of choice for pain management?
Oh, this is like, we debate this forever. So here's the thing with pain medicine and abdominal pain. Couple things. If it's constipation, we don't want to give narcotics because it's just going to make things worse. And we don't want to mask pain and then get tricked that the patient's pain is gone because they had an opioid. I'd say most likely that's not going to happen, right? Like kids with appendicitis who get morphine, they still have pain. They just kind of don't care as much about the pain. So if they are writhing in pain and you feel pretty good about, you know, maybe what it's due to. I think giving some fentanyl is okay because it's not going to last that long. Tylenol is always fine. Tylenol, ibuprofen is always fine to give. But it's tricky. The abdominal pain and pain medicine thing is tricky. So I don't have like an exact answer for you, but
one thing that I want them to remember is that there's lots of non-pharmacological ways to manage pain too. And a good heat pack and a good cell phone with some games on it is a great distraction.
You know, heat pack, some Tylenol. But yeah, it's hard. That's a hard one.
Here's another question. What are the studies showing with trauma and TXA in pediatric patients?
Oh, well, we haven't restarted. I don't think we've restarted our study. And I don't think there are any good, I mean, we were part of, they're trying to do a PECARN study, and I think it got shut down at the beginning of COVID, right, Tia? Do you recall?
Yeah, as far as I know.
Yeah, and I don't think it's started up again. So at this point, I don't think there's a lot of good data on a TXA in abdominal trauma in kids that I know of. You guys probably would know even more than I would, but I'm not up on that literature.
We are reaching our time limit, folks. Would anyone like to unmute and ask any other questions? I could play the Jeopardy song.
do y'all get many calls, not trauma, not a trauma call, but just general calls for abdominal pain? Is it a common complaint for you? Anyone?
In the chat, they're saying I haven't had many, not often.
Yeah.
A lot of times what we'll see as far as EMS goes from reports that I've talked to them, they get the phone call, but by the time they get to the scene, the pain has resolved.
Yeah.
Like a constipation, or it's an abdominal cramping, or it's an intussusception. And so they send the ambulance away.
Yeah.
That's what you guys are seeing? Head nods.
There's nothing like a big diarrheal stool to make your abdominal pain go away. It solves lots of problems. So
it's the first thing I tell my kids when they come and say they have a tummy ache. I say, go sit on the toilet.
Sit on the toilet, I know. So well, it's been a real pleasure. Please say hi when you come to the ED. We love to see you all, and would love to meet you. And we might even recognize you someday if we're not all in masks.
Joyce, thank you so much. This was fantastic, and I'm getting tons of good feedback.
Oh, great.
So I will send that to you.
We love you all and what you do, and we couldn't function without you. That's for sure. You're all really awesome. Take great care of our kids out there. So.
All right, guys, expect your certificates sometime this afternoon. If you do not get them, I want you to email me, tdixon@utah.gov, so that we can make sure that you get credit for attending today. Join us next month. This is always the second Monday of the month, and we are happy to have you spread the word for us. Also, check out EMSC Connects, our newsletter. It came out this morning. If you don't have it in your personal email, jump online, Google it, and make sure that you're following us, because it's free, it's digital, it gives you all good stuff about pediatrics. And I'm going to stop our recording right now. And